It's my pleasure to introduce the next speaker, Dr. Fabian Emura. And Dr. Emura is an advanced endoscopist and gastroenterologist from the University of Miami. He's a work expert in interventional endoscopy with extensive expertise on using endoscopy to diagnose and screen and treat an early gastric cancer. Welcome.
So thank you very much. I'm very happy, I'm honored to be here. Thank you very much, Juha, for making me part of this amazing summit. My talk is on endoscopic screening for gastric precancerous lesions. These are my disclosures. I'm going to talk a little bit again about Dr. Parsonet has referred to. Certainly, I'm going to focus on the red items that are here, that are atrophic gastritis and intestinal metaplasia. And want to say that if we want to detect gastric cancer, but if we don't recognize atrophic gastritis and intestinal metaplasia, certainly we may not find early lesions because the cancer is coming up later at the end of this cascade. So better to identify this. And I have brought a bunch of images for you to realize how simple is to identify these precancerous lesions. Here are two examples. This is, here there is a loss of gastric folds in this middle third of the gastric body with a little bit of erythema and some areas of atrophy here. And then this is an elevated lesion, of course, suggesting an advanced cancer. So white light is the main technology to identify atrophy. And as you can see here, there are vessels. When you look at vessels, mainly in the lesser curvature, this is gastric atrophy. But sometimes we are now looking at the lesser curvature, even as the most important place that we need to look at, because when we look at early gastric cancer location, most of the cancer are located in the lesser curvature. So how about MVI? MVI is the very technological instrument that we have to detect intestinal metaplasia as a patchy whitish mucosa. You can see here how nicely is seen the light blue crest, and this is the WOS described by the Japanese experts. So what is the relationship between this and gastric cancer? This was nicely demonstrated more than 10 years ago by Dr. Emura, saying that the more severe the atrophy is, the higher risk for developing gastric cancer. You can see here there is a 4.9 relative risk of having the disease. So how about intestinal metaplasia? This article was also the first to present that when intestinal metaplasia is present, the relative risk to develop gastric cancer was 6.4. So I have brought kind of our group proposal to screen the stomach in a way that no gaps are left behind in the stomach. So this was our patent as an invention patent, and we are not getting some loyalties about this in terms of finances. So I'm going to show you quickly how it is this about. We start looking at the pylorus, and then we go clockwise, screening the antrum. And the very important concept here is endoluminal orientation. So the antrum is divided in anterior, posterior, lesser curvature, and posterior wall and greater curvature. And then we go clockwise manner, pulling back, looking at the lower third, middle third, and upper third of the stomach. I think this is the best way to screen the stomach because it's systematic and it's sequential. And on the other hand, every station has a name and a number, so you can teach your young fellows and to do some very nice and quick examination without gaps. Certainly, there is no atrophic gastritis here, not even intestinal metaplasia, just gastritis in the corpus and in the antrum. Here, the scope goes inverted. That means in the retroflexion view, to take a look at the gastric fundus, and goes all the way around to look at the cardia. This is the best way to look at the lesser curvature at the upper part, where the actual seaward tumors locates, and then up in the gastric incisura. This is a 27 station and ends up in a 28, which is the duodenal bulb. And then you can use MVI. MVI is almost in every major facility now, and look for the light blue crest and the WOS signs that are obviously not here, not even in the antrum, not even in the greater and the lesser curvature. So what are the drawbacks in our days? Number one is that using white light endoscopy, if you have had an endoscopy, it was like this, full of saliva and bubbles. So I think you agree with me that looking at gastric atrophy here is very difficult. So how about NBI? I point out this years ago in the American Journal of Gastroenterology, because there has been a repetitive practice like this, so there is room for improvement, and we need to come up with some mixed cleaning solutions in order to identify gastric precancerous lesions. So how about MVI? I wrote this in 2008, and I think it remains the same in our days. Modern optical technology like MVI without proper image interpretation wastes resources, confuses untrained endoscopists, and delays interinstitutional validation studies. So there is a lot of room for improvement, for teaching and education in terms of identifying precancerous lesions like atrophy and metaplasia. And this is a very nice study that actually gives the fundamentals for Olga and Olgin that Robert has mentioned before. Basically, I want to say that the inter-observer agreement for the pathologies that are here was fair for dysplasia. That's why it's very difficult to interpret for us dysplasia when patients are coming to our unit with dysplasia that it was diagnosed in the stomach. And certainly we don't know where is the dysplasia, so I scoped our patients and there are no lesions. But dysplasia was reported in the pathological report. So these patients are basically needing follow-up, right? Because we cannot resect this type of lesions because we are not seeing that. So what about for atrophy? Is substantial, the agreement, but it's almost perfect for intestinal metaplasia, and that was also highlighted by Robert in the last talk. And the conclusion of this very nice paper is that Olgem might be the preferred over Olga for the prediction of gastric cancer risk in patients with gastric premalignant lesions. So we will be endoscopy taking over biopsies. That means the optical biopsy. We certainly don't know. Here are some pros and cons. Histology examination is the gold standard, but it is costly for the health system. Blind biopsy cannot evaluate the real distribution of atrophic gastritis and intestinal metaplasia. And on the other hand, sample here may lead to incorrect estimation of these lesions. High definition imaging is very nice, but it's costly and may not be available in all facilities. And the recognition of these lesions require expertise and training. So here I brought two images of the lesser curvature. The one on your left is a normal lesser curvature, and the other one is an atrophic mucosa. And it's basically because two findings. Number one, visible vessels, as I mentioned earlier, and loss of folds. If you look at this and identify atrophy, biopsies are necessary here. This is a Kimura Takemoto classification, which is actually kind of difficult to apply in Western countries. It needs, training and expertise, but it's proven in Japan that is a reliable method to identify atrophy. And here are those images about intestinal metaplasia, quite difficult to understand or to look at this in white light imaging, but very easy to identify this whitey spots, plaques on MVI imaging. So I want to recognize that Dr. Ueda back in 2008 published this light blue crest sign, and then he proved that with CD20, the immunostaining just attached to the brush border of the cells, identifying and confirming that was intestinal metaplasia, that what he was looking at. The endoscopic grading of gastric intestinal metaplasia was nicely reported in this article in 2019. This is a GYM. And they basically did a high-resolution wide-light gastroscopy followed by MBI. They took biopsies and developed a new score. And at the end, the conclusion of this very nice study is that the risk of gastric cancer can be estimated without the need for gastric biopsies. That's why this is very much, helping us to identify intestinal metaplasia in our patients. Again, these are the endoscopic features of MVI and intestinal metaplasia. And this very nice study from Japan, very recent study, demonstrated that light blue crest and WOS are also significantly associated with the risk of gastric cancer. And this was compared with biopsy. For the biopsy, the target biopsy with targeting intestinal metaplasia, which is the GYM, and the OLGYM, And then all of this has demonstrated we can certainly diagnose intestinal metaplasia using both target biopsies and also using not targeting biopsies randomly in the stomach, but just focusing in the lesions. So how about characterization in white light? I have a nice lesion here. I don't know if you can identify that. And that's the importance of MVI technology. Right here, I can trace the margin here. This is certainly an early gastric cancer. It can be easily treated by Dr. Yahagi with the ESD techniques. And again, as I start my presentation, if we don't identify intestinal metaplasia or an atrophy, that will be very hard to identify gastric cancer. This is a courtesy of Dr. Ueda. And using MVI magnifying, he can nicely identify the light blue crest surrounding all the high-grade dysplasia and this lesion. It's right here. You can see this, proven by CD20. So my take-home messages are atrophic gastritis and intestinal metaplasia can be certainly identified during routine systematic screening EGD. So you better to be, sequential and systematic to do EGD in your patients. Atrophic gastritis should be identified using white light, not MVI, white light. And you should look at the loss of gastric folds, pale color of the mucosa, and increased vessel visibility. When it comes up to intestinal metaplasia, whitish, multifocal, patchy mucosa, villiform surface structure, and the light blue crest, as I show in that video. And the assessment of gastric cancer by histological diagnosis of intestinal metaplasia can certainly be done by all this, but also using random biopsies by the GYM and OLGYM. So what is your diagnosis here? Atrophic gastritis, foveolar hyperplasia, intestinal metaplasia, low grade, or early gastric cancer. This is the upper part of the stomach. This is the area 22. Look at the cardia. So probably it's not what some of you are thinking. This is not intestinal metaplasia, it's foveolar hyperplasia, so you should not take biopsy from here, right? There are several reasons for this. This is the histological proof that is not intestinal metaplasia. Is actually no metaplasia. There is no atrophy around, right? And this is certainly a very different endoscopic aspect of another lesion. This is the proven histology. And the reason is that the location is right up at the gastric corpus. And when there is no atrophy or metaplasia in the antrum, certainly it should not be present in the upper corpus. You can see intestinal metaplasia and foveolar hyperplasia illustrated here. And what is your diagnosis here? Atrophic gastritis, foveolar hyperplasia, intestinal metaplasia, and erosion plus low-grade or early gastric cancer. Well, this is an intestinal metaplasia and plus erosion, so that means this is the lesions we're looking at. It should be biopsied, and then the patient will start a follow-up, hopefully according to the guidelines that Dr. Morgan is leading every 3 years. And the reason for this is that in spite there is a margin between the inflamed mucosa and the metaplasia, there are no irregularities inside the metaplasia, not even vascular irregularities, and also that is multifocal, as it is a trophy. You see here another spots of intestinal metaplasia. And I'm very much committed to not only to diagnose and treat cancer, but to promote endoscopy among people, mainly those with low social economic class in Colombia, and been developing early gastric detection campaigns for free for almost 20 years. I'm run this foundation, the Emura Foundation. I'm the founder, and I really believe that gastric cancer is preventable, treatable, and beatable. Thank you very much.